Good morning and welcome. We begin this gathering by acknowledging the land on which we gather is the traditional territory of the Haudenosaunee and the Anishinaabe peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging reminds us that our great standard of living is directly related to the resources and friendship of Indigenous people. Welcome to the District School Board of Niagara's 8th International Concussion Summit, Prevention, Diagnosis, and Treatment. My name is Mike St. John, the MC for this year's event, and I am going to be honest with you. This year, there's quite a bit of pressure standing up here in this role, as the bar was set very high in years past. Many of you who have joined us previously will know that for our 7 previous conferences, Kevin Graham brought his amazing and unique blend of professionalism, absolute commitment to the success of the ICS, and humor to this position, while ensuring all conference delegates were informed with the right information at just the right time. As well as keeping everyone entertained, he respected our renowned speakers by keeping the programming running smoothly. I feel privileged to have been given this opportunity and will do my absolute best to perform in this role to the high standards set before me. Kevin will always be an honored guest and will join us at some point during these 2 days, if only to show up to remind me that I need a haircut, that my suit is too skinny, and that I am the new guy. We look forward to seeing him at some point during the next 2 days. This summit is made possible thanks to the vision of the DSBN Director of Education, Warren Hoshizaki, and Dr. Blaine Hoshizaki, and the hard work of our ICS team, Colleen Fast, Roy Smith, Jennifer McGugan, and Lori Koje. As the world slowly works its way back to normal, we are truly grateful for your attendance here with us today. Despite scheduling the summit as late as possible in the school year to allow for in-person conference, and the loosening of restrictions at every level, the reality of the pandemic is still impacting travel and gatherings such as this one. Please know that the commitment by this team to coordinate, organize, and lead the ICS for its 8th year is as strong as ever, and we are absolutely confident this will be the best one yet, and that you will leave inspired and even better prepared to lead this work back in your communities. A sincere thank you for joining us and making this experience an in-person event. That you made the commitment to be here, allowed this to happen, and it means a lot to all of us. To that end, we are so excited to have representation from 33 school boards, 6 universities, and 10 healthcare organizations. Today, we welcome many teachers, consultants, nurses, superintendents, school administrators, directors of education, health and safety officers, athletic and physiotherapists, and so many more from across various sectors. Others joining us virtually from locations far and wide, including Scotland and places even farther north than Dryden, Ontario. This year's summit is proudly presented once again by the District School Board of Niagara and OFIA, and funded in part by the Ministry of Education, Safe and Healthy Schools branch. At this time, I'm very pleased to introduce Director of Education for the DSBN, Warren Hoshizaki.
Thank you, Michael, and you do need a haircut. On behalf of the District School Board of Niagara, it gives me great pleasure to welcome you here today. Thank you for taking the time to come to our summit. You're an essential group who are on the front lines of concussion education and prevention. You are educators, coaches, healthcare professionals, community agencies, and parents. And by being here today, you are emphasizing just how important concussion education is. Education is the key. The same is as true today as it was back in 2012 when we first held our initial International Concussion Summit. I remember at that time a few high-profile athletes, the likes of Sidney Crosby, were suffering through an impacts of concussion and from concussion-related issues. Their stories triggered huge public interest in this issue, and it was an opportunity time to review the way we as a society dealt with the types of injuries. Since that time, school boards across Ontario have revised their policies and procedures to help teachers and coaches better identify and properly manage concussion. The Ontario Ministry of Education has made concussion education in our schools a priority. This has been a critical step forward in recognizing the truth about concussions and the severe impact they can have on a student's life. Legislation like Rowan's Law has helped to drive concussion education across Ontario and Canada. Rowan Stringer, a celebrated high school athlete, died at the young age of 17 after suffering multiple concussions while playing rugby 3 times in 6 days. Rowan's story is tragic and unforgettable. By naming the law after Rowan, we're always reminded of why this law is in place and about the devastating impacts of concussion. Ontario became the first jurisdiction in Canada to address concussions through legislation when it passed the Rowan's Law. As a member of the Ontario Rowan's Law Concussion Working Group, I've had the privilege of working alongside Gordon Stringer, Rowan's father, and other members who are committed to raising awareness about concussions, advocating for change. As a group, we are hoping to continue this work this fall. And thankfully, as a result of concussion education and awareness among Canadians is growing. We are making progress, and progress is necessary. We have begun to see attitudes and culture toward concussion change, especially in the sporting world. Together, we put that old dangerous practice of shaking it off to rest. But as we all know, a concussion can happen anywhere, not just on the sports field. They can affect a student's ability to learn, to focus, and even to simply function in their classroom. As the research and comprehension of concussion has become more sophisticated, so has the diagnosis and treatment. I want to give a special thank you to the world-renowned experts that are here today to share their knowledge and experiences with us over the next 2 days. Dr. Robert Cantu, Dr. John Letty, Dr. Janie Cornway, Dr. Judy Stam, and I guess I have to say, Dr. Blaine Hoshizaki. I had a lot of notice before it happened, so I locked my wine cellar, I locked my fridge, I locked the cookie pantry, but somehow he was able to open them all. The only good thing is, he's on Friday and I can sleep in. They will be informing us of the latest research, debunking myths, and equipping us to the knowledge to help us understand how to improve prevention, diagnosis, and treatment of head injuries. And I know that there are many, many students and families who are grateful that we are prioritizing concussion education and therefore prioritizing health, safety, and well-being of students. In between our esteemed presenters, we'll be showing some vignettes from people who aren't able to be here today, including Nancy Naylor, Deputy Minister of Education in Ontario, Paul Hunter, Rugby Canada, Dr. Charles Tater, as we all know. And I think this is one of the first years that Dr. Tater has not been able to attend and present. I look forward to seeing him on the screen. Once again, thank you so much for participating in this summit. We appreciate your attendance and your willingness to learn. Have a great day.
Thank you very much, Warren, for your leadership, guidance, vision, support, and that amazing opening and welcome to the group here today. And if you weren't the director and held my future in the palm of your hand, there'd be a hair joke coming right back at you, too. For those of you active on your socials and happen to be tweeting about your experience at the ICS, our hashtag for the conference is hashtag ICS Niagara. It can also be found in the backs of your programs. And once again, as I mentioned earlier, our summit is being streamed live for those who cannot attend, and that link can also be found on our ICS webpage. To officially open the 8th International Concussion Summit, our first keynote speaker is a retired ice hockey goaltender we all know from the National Hockey League and a goaltending coach for the Arizona Coyotes, Mr. Grant Fuhr. In 2003, he was inducted into the Hockey Hall of Fame. He's best remembered for a decade of stellar play for the Edmonton Oilers in the 1980s, and he won a staggering total of 5 Stanley Cups and was a 7-time All-Star. On January 27th, 2017, Grant was named one of the 100 greatest NHL players in 100 years of NHL history. He was recently appointed to a head coach position with the new 3-Ice Professional Hockey League. This is a 3-on-3 hockey league featuring many former NHL players who are currently playing professionally, along with many NCAA players. It involves a 9-city tour playing in a tournament format, and it begins this summer. Mr. Fuhr has also established a not-for-profit charity, the Grant Fuhr Foundation, which hosts an annual celebrity invitational golf tournament in the Palm Springs area, helping to raise funds for much-needed charitable organizations locally in the Coachella Valley. Please join me in welcoming Hall of Famer Grant Fuhr. Thank you, Grant, for joining us, contributing to the International Concussion Summit. All the best to you and safe travels in the rest of your day. I do have a couple of reflections since we have a bit of time. First of all, last night, and all related to Mr. Fuhr's conversation, chatting with him by text last night, I thought I was kind of a big deal. He got in here safely, let me know he loved the hotel, everything was going great, and the Hall of Famer invited me for coffee this morning. And I felt pretty good about myself until I learned he's been doing it since he's been 17 with everybody under the sun. I was just the guy today that he was having coffee with, so that was one thing. The other thing is about leadership, and we're really blessed by the amount of support of our DSBN colleagues, teachers, consultants, SOs, the number of people that are here and support this, not only in person here today, but the work that they do in their schools. They support Roland's Law Day, and the work day in and day out around concussion awareness is amazing. This extends to our amazing senior team who support this vision, and this comes to our senior team every year about the Concussion Conference and moving forward with it. And every one of them are here today to support this. And I'm really proud to call them friends and colleagues. That's right, Lauren, I said friends. And since you're all here, I've got a question for you, and it's about Grant's discussion on leadership, which is a great question by a young lad out in the seats. They talked about Gretzky being a quiet leader and Messier being in your face. So please take out a sticky and write down which one you think Warren is, and we will discuss on Monday. Somebody write that up as an agenda item. I've heard he might not even be here Monday, so it's going to be perfect for us. Prior to our first plenary speaker, there's just a couple of important items to share with you about the day. If you require assistance with anything, we have a number of volunteers to help. They will have a blue band down the side of their name tag that says ICS team. We also have a number of members of the DSBN Rowan's Law Committee here to support as well. Our golf shirts are getting a lot of love here today. I'm sorry, next year we'll have them for sale. But they're wearing the purple golf shirts, and they can help at any time as well. Just please check in at the registration desk if you need support. Lunch today will be served in the Brazza restaurant, which is on this floor, just that way, just down the hall, from 12 to 1:15. If you have not joined us in the past or enjoyed Brazza, just simply follow the herd of people heading that way as fast as they can. There's never any delay for people heading to Brazza when the opportunity presents. And for everyone in attendance on Friday, a quick note that breakfast will also be available at Brazza, and this is different than what is shared in the promotional material, so there has been a change. Breakfast tomorrow is at Brazza, and it will be great. Wherever you go around here for the complimentary food, please be sure that you have your name tag, because that's your in and out. And at this time, we'd like to thank our many sponsors, exhibitors, and presenters for their various contributions to the summit. We could not have offered such a comprehensive conference experience for all of you as delegates without all of that support. So we thank that group and those individuals. As we move along in our program this morning, please note, as we did with Mr. Fuhr, that at the end of each of our plenary speaker sessions, even though it's not noted in your agenda, that there is opportunity, as we have here today, to move to the microphone and ask any questions that you might have. So it's now time for our first presenter of the conference, and what a great way to begin. It is my honor to introduce and welcome Dr. Robert Cantu. Dr. Cantu is a clinical professor in the Department of Neurology and Neurosurgery, Clinical Diagnostics and Therapeutics leader, AD and CTE Center at the Boston University School of Medicine, a medical director and director of clinical research at the Dr. Robert C. Cantu Concussion Center, Emerson Hospital. He has authored over 522 scientific publications, including 34 books on neurology and sports med, in addition to numerous book chapters, peer-reviewed papers, abstracts, free communications, and educational videos. Dr. Cantu serves as senior advisor to the NFL Head, Neck, and Spine Committee. He's a founding member and medical director of the Concussion Legacy Foundation and consults with many various national and international concussion boards and advisory groups, research centers, hospitals, and professional sports teams in the NHL, NBA, and NFL, and so much more. Dr. Cantu has presented many times at the DSBN International Concussion Summit and has contributed tremendously to the ongoing success of our event. We are honored he has joined us again this year. Please join me in welcoming Dr. Cantu to the podium.
Thank you, Michael. Thank you, Warren. Thank you, Blaine, for having me back. It's certainly a pleasure to be here. I don't thank you for having me follow Grant Fuhr. I could listen to him all day long. What a treat to have the experience with a Hall of Fame goalie, but what an even better human being. It was just very, very special. Been around a long time, so we're going to talk about some lessons that I think I've learned over the last 50-plus years diagnosing, treating, and researching on concussion. And then we're going to shift for the second half of the talk to go into a subject that is kind of the elephant in the room. Chronic traumatic encephalopathy has been around for a long time. There are over 100 papers written on it every year. We have nearly 1,000 brains with CTE in our BU CTE Brain Bank. It's a real entity, and we're going to focus on the second half of the talk with where we are today in terms of diagnosing the probability that we're dealing with CTE in a living individual. As you all know, it can only be diagnosed with absolute certainty by looking at the brain after one's dead. But we're getting closer to having levels of probability in living individuals. Some disclosures, but no conflicts. Talking about concussions, one of the subjects that constantly is being asked is, are we seeing more concussions today than we saw 20, 30 years ago? And I think the answer to that is yes, but I think the answer to being yes is multifocal. The first writings of concussion go back to the 10th century AD, but when I got into the concussion work a little bit later than that, in the 60s, concussion was pretty much synonymous with being rendered unconscious. That's kind of what we were mostly talking about with concussions. And concussions mostly were relegated to automobile accidents, motorcycle accidents, falls, so on. We didn't really recognize it very much in athletics. And then as we got into the 80s, it became, well, we're recognizing that symptoms happen after traumatic brain injuries. You don't have to be rendered unconscious to have a concussion. So it became a more liberal diagnosis. And then as we've gotten into the 90s and certainly 2000 plus, concussion now is mostly synonymous with traumatically induced brain-related, primarily, symptoms. And as we go into the future, we're still kind of defining and still tweaking the diagnosis of concussion with an emphasis trying to get some of the cranial nerve and some of the cervical spine symptoms out of the diagnosis and leave it as a pure brain diagnosis. But if we quickly look at these acceleration patterns that are so familiar to Blaine, when we were talking about concussion being rendered unconscious back in the 70s and before, we were talking about higher radians per second squared than as we got more liberal with the diagnosis, the average back then being around 5 to 6 radians per second squared. As we got to loss of consciousness and or traumatically induced brain symptoms, the radians per second squared halved around 3, 3.5. And as we're talking now about traumatically induced symptoms in cognitive, in somatic or physical symptoms, in buckets of sleep symptoms, in buckets of cervical ocular symptoms, in buckets of emotional symptoms, we're really talking about acceleration forces that are even less. So I think the answer in terms of are we seeing more concussions today, I think the answer is yes. I think it's primarily or largely because we're recognizing them better, the doctors are better educated, the players are better educated, they're reporting their symptoms a bit better than they did way back when, though far from perfectly. But in addition to that, our diagnosis has become more liberal, and you don't have to have quite the acceleration forces to produce those symptoms. So I think everyone in the room knows that a concussion is a traumatically induced brain injury, and I think it's important to think of it as a brain injury. And I think it's not a good idea to think of it as a mild traumatic brain injury. It is true that in the purest form, there isn't recognized hemorrhage, there isn't recognized macroscopic injury. But at the microscopic level, there can be microhemorrhage and there can be disruption of nerve fibers and nerve cells. And certainly about 20 to 25% of people with concussions, depending upon what literature you want to cite, depending upon what your experience is, we see them all the time in terms of our concussion center. About that percentage of people will go on to persistent symptoms, and a smaller percentage will go on to symptoms that last many, many months, if not beyond a year, and a few will even have permanent symptoms after a concussion. So I don't think it's a good idea to think of as a mild traumatic brain injury. I also don't think it's a good idea to think about the severity of it at the time it happens. Think about the severity of it when all the symptoms have cleared up, when you know how long the symptoms have taken to clear up. Back when I got in the field in the 60s, almost all of the concussion treatment and research was being done by neurosurgeons, because as neurosurgeons we took care of brain injuries, and on the one end of the spectrum was concussion. But over the years, that's not been the case. Over the years, other specialties have taken a lead role in concussion research, and our wonderful biomechanists have added tremendously to our knowledge. And today, neurosurgeons think they're at the center. I don't really do, even though I'm a neurosurgeon, but those are all the specialties contributing concussion research and concussion literature to the science. I got involved basically with athletic concussions in the early 70s when, having moved to the community from Boston, where we're still on staff at Mass General Hospital, where we trained, we were asked by the local high school to basically be the team doc. And so suddenly we're taking care of various things, but among them were concussions. And it was amazing to me to think in the early 70s there were no return to play criteria for athletic concussion. There was some literature about it in terms of automobiles and other things, but not in terms of athletes. So that led us a few years later in 1986 to write the first return to play protocols for concussion, to put in a concussion severity grading scale that later became amended in 2001 when we realized that in athletic concussion, you almost never have concussions that are lasting 5 minutes in duration in terms of loss of consciousness, lasting 5 minutes. It's always, almost always seconds, and rarely beyond a minute or two. And the way most people get into the severe grading of concussion, if you're going to use a grading scale, is persistent symptoms, symptoms that haven't cleared within a week or two. Now, the grading scales have fallen by the boards, largely, I believe, for political reasons, but I think it's very important, as anyone who's following somebody with a concussion, treating them, or just aware of them, to not disregard how severe a given concussion is. And don't treat somebody who has had symptoms that last many months or a year the same as you might treat somebody who had symptoms that just lasted a day or two or three, because clearly a head injury with symptoms lasting a prolonged period of time is not the same severity of brain injury as somebody that has symptoms that last a year or more. Back when we wrote those first return to play guidelines, we also had guidelines in terms of when you might be safely able to go back and when and how long you might be held out. And as you might expect, with more minor concussions that cleared quicker, we let people go back sooner. If someone had symptoms that lasted a protracted period of time, we asked people to stay out longer. It's interesting that we still today are tweaking these return to play guidelines, but I think the unanimous thing that is out there from the many consensuses is that you should be asymptomatic at rest and exertion before you put through an exertional protocol. And then the longer one has had persistent symptoms and been out, you're probably going to be a little bit more conservative about when you let them go back. Over 40 years ago, when those guidelines were put out, we were aware that we needed an adoption of a uniform definition of concussion, and wouldn't you know it, those definitions are not really uniform today. They're still being tweaked. That's not all a bad thing, because science isn't static. Science, by definition, is really constant learning. So this constant tweaking, I don't think is a bad thing. I think it's a good thing. One of the things we recognized 40 years ago was we needed a huge amount of additional information in the repetitive effects of head trauma, the cumulative effects of concussion especially. And this is something we still are researching today. It's still a very important area, and one in which we have a lot to learn. When we talk in a moment about CTE, we're not primarily focused on concussion, we're primarily focused on cumulative head trauma, thousands and thousands of hits, whereas concussions contribute. We can't correlate the number of concussions with your risk for CTE. We can correlate the cumulative hits you've taken over a lifetime with your risk for CTE. These are just some of the concussion consensus groups that we've been a part of through the years, and the papers that came out of them representing a number of different organizations. These continue today because the science continues to evolve and it's very needed to change. So what are a couple of messages that we think are very important, that we believe that we've learned with 50 years in this field? Number one is concussion is a diagnosis that is most accurately made by using multiple tools. There's no one tool unless someone is rendered unconscious, and you really don't need more tools in documenting that. The more tools you use, the better chance you're going to have to recognize concussion and recognize when a concussion is cleared and when it's safe for somebody to go back to contact or collision sport. And at the very minimum, the tools involve a concussion checklist. We use a 26-symptom checklist. Most people in the concussion field do use a checklist. We note not only the number of symptoms somebody has, we call that the load, but also the severity, ranking them 1 to 6 of how severe the symptoms are for a severity score. And the thing that's held up best over the years in terms of who's at risk to have a slow recovery for a concussion, although there are a number of risk factors that can be red flag that somebody might have a slow recovery. But the thing that correlates best is how many symptoms you have shortly after your concussion is recognized and how severe they are. A very high severity number, a very high load number makes it highly probable this person might not make a really quick recovery. But the other legs of the stool, which I think of as a four-legged stool, with a checklist here, is a very detailed cognitive assessment, because our abilities to process information correctly and rapidly is impaired with concussion very frequently. And even when one can process information correctly on the way to recovering, they will often process it much more slowly than they were before their concussion. And then when they're totally over their concussion, the processing speed will be back as well as the accuracy. Balance is also something for a number of years that's been looked at after concussion, especially within the first 48 to 72 hours. And so detailed balance testing involving a Romberg test with the feet together, hands on your hips, eyes closed, 20 seconds, eyes open, 20 seconds, eyes closed, should be able to do that. Tandem stance, where you put one foot in front of the other and do the same thing. And then single leg stance. Slowly you're making the platform less and less, and it's more difficult to pass. And then in the last 10 years especially, the eye tracking has become particularly, I think, useful in following people with concussion, as many people will have vestibular ocular symptoms and will have abnormalities on saccadic eye movements or vestibular ocular reflex, what we refer to in our testing schema as the VOMS test. Another thing that we believe strongly is that concussion is a metabolic injury. I think we've all pretty much felt that for 30 plus years since the wonderful work of Dave Hovda that's been carried on by Chris Giesa at UCLA. But concussion also is a structural injury in many individuals. We've had personal experience seeing that in individuals that tragically have died shortly after concussion from other issues, and then their brains have been examined, and axonal swelling or disruption of axons and neurons have been seen by Dr. Ann McKee, the lead neuropathologist in our BU group. The metabolic flux that happens after concussion, it's not important that you know it in any great detail, but it involves ions, mainly sodium and potassium, within the cell going to the extracellular space. It involves ions from the extracellular space, calcium primarily, going intracellularly to replace it, but it, in the process of doing that, shuts down the metabolic pump, the ATP pump, that happens, and therefore there's a metabolic crisis that's occurring as a result of these changes. And the neurotransmitters at the end of the axons are chaotically released. This all happens paradoxically during a period of reduced, though not critically reduced, blood flow, which tends to make an even bigger metabolic challenge. With regard to the structural injury with concussion, it was really known a long time ago and reported in the literature a long time ago, as far back as 1871 by James Crichton Brown. And there were other pathologists who documented structural changes after concussive head injuries in the world's literature. And this has been proven, as I say again, by the work of Ann McKee and others, but there are primarily two longitudinal studies currently ongoing in the United States today. One is an NIH-funded track TBI study of head injury, predominantly in the emergency departments, starting from concussion to coma, and then tracking these people longitudinally for many years and looking at these individuals with very sophisticated MRI methodologies. And then the other longitudinal study that's primarily in athletes is the NC2A Department of Defense CARE study, looking at college-age athletes, not only while they're in college, but fortunately now longitudinally beyond. And I think out of these two studies, we're going to be able to see a better indication of the structural issues that are going on with concussion and people that have post-concussion syndrome. A third thing about concussion is it happens because the brain is violently shaken. Most of the time because the head is hit, but it can be just simply a whiplash effect of a hit to another part of the body, your back, and snapping your head back, or chest snapping the head forward. If you can reduce or if you can eliminate that head motion, you can dramatically reduce the likelihood for concussion. And this was shown a long time ago, back in the 40s, in research at Boston University, Boston City Hospital, which is now Boston University, in this work by Tedeschi, in which in one case the animals were with a moving head impacting a solid object, and in the other case the head was not moving and the object was moving, impacting the head. When the head didn't move, there was much less chance for there to be loss of consciousness or death as compared with when the head is allowed to move. And I think this is dramatically shown in these two videos. This is tragically in 2001, Dale Earnhardt Sr., impacting in the last lap of the Daytona 500 the wall, T-boning it really. Don't want to get into whether or not seat belts were lax and this, that, and the other, but he did not have any head and neck restraint. And literally the weight of his helmet, the force with which he struck the wall, the front of his car, his head was snapped forward with such force that the head was literally pulled off the top of the cervical spine. Atlantoaxial dislocation is what he had. Others can refer to as a basal skull fracture. It's really not a fracture, it's a ligamentous injury. He died instantaneously, and he was the fourth person to have died that year from that injury in NASCAR, with Tony Roper and Adam Petty, the heir to the Petty dynasty, dying from the same injury. Out of that came mandated head and neck restraints in NASCAR, the so-called Hans device, which already had been mandated in Formula One racing and had been used in sports car racing as well. The efficacy of that device was known in those circles. It was mandated in NASCAR, and NASCAR has not had a death from that mechanism since in the top 3 levels of NASCAR. To show how effective that can be, though, let's take a look at Dixon in the Indianapolis 500 a couple of years back when he was clipped and became airborne. And he's going to come down on the wall, thank God, just behind the driver's compartment. So it was the motor that really took the brunt of hitting the wall. But you can imagine how violent that is. He's moving in the car. He immediately gets out. He didn't even suffer a concussion because his head and neck were restrained. And Indy Racing League has had no deaths from atlantoaxial dislocation since the HANS device has been instituted. They have had deaths from debris hitting a driver's head, and that's why you see now the windscreens that are on all those cars that prevent debris from bouncing up and hitting drivers. Another lesson that I think we've learned in the last 50 years is concussions are not created equal. I think the most important thing in concussions is how long it takes for the symptoms to clear. So the duration of symptoms is probably highest in my mind when I'm going through the concussion history with each patient. But we're also very aware that concussions suffered close together tend to be more of a concern than concussions suffered years apart. And then we also are aware that we don't disregard the number of concussions, but we really can't correlate number of concussions necessarily with how someone's going to recover. And we don't really use today the number of concussions with regard to an individual as any arbitrary way of now it's time to sit somebody down or not. This so-called 3 and you're out story that has appeared from time to time, I don't think is rational. And the reason it's not rational is this: the concussions aren't created equal. When we talk about a concussion or two that lasted a year plus or happened from what seems to be a very minor blow, that would be something that would cause someone to think that that person might not be safely able to go back, much more than somebody that's had a higher number of concussions, but the concussions all cleared within a matter of hours or weeks. And then the final message that I want to leave you with is that concussions are treatable. John Leddy and I both are involved with concussion centers in treating people, and the therapies that are used were the discussion of a group that got together some years ago and a paper that appeared in the journal Neurosurgery about treating concussions and the fact that concussion diagnosis is a interprofessional care team approach. It has normally someone that is at the center managing, but the different people that we have are our therapists, first of all, who treat the various baskets of symptoms that go with concussion, our cognitive therapists that are going to be following individuals with cognitive symptoms and or more detailed testing with neuropsychologists. We're going to have physical therapists that focus on vestibular issues, that focus on ocular issues. We're going to have neuropsychologists involved. So it is truly a team effort in interdisciplinary treatment. All right, concussion is a traumatic brain injury, as we've indicated. It's caused by accelerating the head, either directly or indirectly. Most of the time, it leads to short-term symptoms, though not always. And then generally, 75–80% of people will feel better within 2 to 3 weeks. If you're an adult, maybe a little longer, closer to a month if you're a child. Post-concussion syndrome, on the other hand, is a concussion with symptoms that have persisted. In fact, more today, people are wanting to use the word persistent post-concussion symptoms. I think it's the neuropsychologists that are driving that. I agree that most people with post-concussion syndrome are going to have psychological symptoms, but I don't believe it's purely that in the majority of individuals. In any event, in post-concussion syndrome, the concussion symptoms never clear. They persist, and they persist for beyond a month for most of us that are using the diagnosis. Some of us will use a diagnosis of beyond 3 months. But the point is, you have your symptoms, they may get better somewhat, but they're persisting. There's not a clear period of time where you have no symptoms at all. On the other hand, chronic traumatic encephalopathy, which I'm segueing into, is a neurodegenerative disease linked to primarily repetitive head injury, and a lot of it, thousands of hits in most cases. And the symptoms are going to occur usually after a latent period of 10 or 20, sometimes even 30 years of being fine after you finished your activity that you were taking the repetitive head trauma from. And then the symptoms of cognitive issues, especially with memory, short-term memory, issues with short fuse, neurobehavioral dysregulation, and mood issues with depression, anxiety, will start to occur. And once they occur, they're progressive, and it's a relentless downhill course for most people. Colt Brennan was arguably the most successful quarterback out of Hawaii, University of Hawaii. In the past year, he's died of CTE. This individual, unfortunately, took out a number of individuals, including a doctor and his wife, before he turned the gun on himself. He had CTE when his brain was looked at, as did Vincent Jackson. And I could go on and on and on, because we have nearly 600 football players from primarily the National Football League in the brain bank. But if you wanted to just think about the likelihood of maybe it's just happenstance, think of the undefeated Miami Dolphins football team of 1972. 6 players have died with dementia, and their brains, when studied, have had CTE. Not a coincidence. Our work with CTE started in 2007 when Chris Nowinski, then a former wrestler who had started up, along with myself, a not-for-profit called Sports Legacy that's now Concussion Legacy Foundation. We wanted to find a brain bank to be looking at athletes with suspected CTE. Dr. Ann McKee was the one that we found at Boston University, and she, along with Bob Stern, became our go-to people for the establishment of the Center for the Study of Traumatic Encephalopathy, which was set up to look at mild traumatic brain injury, to have a brain injury bank, to have a brain donation registry, which is now in the thousands, and also to have longitudinal clinical studies. And later, Lee Goldstein on the right was added, and he is involved with the preclinical studies, the animal research that is ongoing. CTE is a neuropathologically recognized disease. It is a unique tauopathy. It is separate from other neurodegenerative diseases, though it can occur, and often does, in association with them. And it is primarily only seen, with very few exceptions, in people that have had a history of repetitive head injury. And the characteristic lesion of CTE is this brown pigment called hyperphosphorylated tau that accumulates in nerve cells, in astrocytes, and in nerve tubules at the depth of sulci in the brain around blood vessels. That's the hallmark of this condition. It's not the whole story for CTE, but it's certainly the neuropathological story of it. If we're going to be able to diagnose and treat CTE and be able to prevent it, and we're going to be able to evaluate therapies, we're going to have a way of trying to recognize it in living individuals. And that process started back in 2014 with Philip Montenegro taking the lead, then a MD PhD student at BU working in the CTE Center. And he looked at the world's literature, along with our group, of autopsy-proven cases of CTE and looked at what reached 80% commonality amongst symptoms or other situations. And what was found, looking at it that way, was that certain things made it more probable that somebody had CTE than not. One, there had to be adequate exposure. In the beginning, we talked about 6 years of a collision sport. We talked about military exposure. We even had a single severe TBI as a possible adequate exposure. That is fallen by the boards, as you'll see in a moment. And then at least one core clinical feature, cognitive impairment as manifested by recent memory issues or executive function issues, insight, judgment, that type of thing, or behavioral dysregulation, short fuse, impulsivity, or psychiatric mood symptoms, anxiety, depression. You'll see in a moment that's been refined. And or two supportive features, such as suicidality, headache, or Parkinsonism. That's where we started. You'll see how it's been changed. In 2021, Jesse Mez led the group looking at using that criteria for traumatic encephalopathy syndrome, which is essentially CTE in living individuals, looking at 336 consecutive cases of CTE proven by neuropathology in which we had the history from significant others. And applying that criteria, how accurate was that criteria? How good was it? Well, it was pretty good in terms of not missing cases of CTE. If you had it, 97% of the time, the criteria would kick it out. But it wasn't very good about being specific. A lot of other people with other conditions kicked out with positive TES syndrome. In other words, the positive effect was not very good if we look at it in terms of excluding CTE. When you looked at the various different criteria, the cognitive ones stood up pretty well. If you had cognitive issues, they correlated highly with your probability for CTE, but the behavioral dysregulation and the mood symptoms didn't correlate very well. And they didn't correlate very well because there's so much of that problem in society today that if you're using it as a criteria, you're going to have a lot of false positive, a lot of people in there with other issues, with other psychiatric issues. Using that knowledge, a group was put together and a research grant that actually totaled $16 million over 7 years was obtained from NIH or NINDS with Bob Stern and 3 others as the co-PIs on this study with over 50 collaborators in 10 different institutions. It's an interdisciplinary group. It involves people from a lot of different backgrounds. As indicated, it involves 10 different university centers. And the aim of the grant was to characterize the clinical presentation of CTE examine the progression of it over a 3-year period. So individuals would be studied in the beginning, and then 3 years later, they'd come back for a follow-up study. It also attempted to refine and validate the diagnostic criteria for CTE and investigate genetic head and impact risk factors and also biomarkers for CTE. Pretty impressive undertaking. The people that were being studied were all male, 45 to 72 years. There were 3 groups. The largest group was NFL players who fell into 3 different baskets: no symptoms, mild symptoms, or dementia, and 60 college players who fell into the same group, and then there were also 60 controls who had not been exposed to repetitive head injury through contact sports, and all of the controls had to be asymptomatic. The hope study is that if we could diagnose CTE in life, then we'll be able to recognize it early on and start preventive measures or treatment measures before one has become significantly symptomatic from CTE. The group that was put together included a panel of 20 of us from all those backgrounds, as I indicated. We looked at all the published cases of CTE in the world's literature with pathological confirmation, including 298 cases from the BU Brain Bank at that time. And after 4 rounds of a modified Delphi consensus criteria, which basically is 80% agreement, the criteria that we're going to give you now is the state of the art in terms of diagnosing the probability of CTE in living individuals. And this came and was published in Neurology in 2021. Doug Katz was the lead author. Some big changes. We really have data on football, and we don't have enough data on ice hockey, and we don't, even though we have 50, 60 ice hockey players, it's not like the nearly 800 football players. So the adequate exposure to repetitive head trauma, we took out collision sports as a group, we took out military, we took out single brain injury, and we substituted 5 years of football or 11 years of football. 5 years got you into substantial risk. Extensive exposure, 11 years plus, got you into a much higher risk. The core features became just cognitive and or behavioral dysregulation. You'll see in a minute how much we changed around the importance of the cognitive. And we changed around the supportive features, taking out suicidality, headache, and others because there wasn't sufficient data to not say that they aren't important, not say that they're not associated, but very difficult to say exactly what the role. So the criteria as they currently are published for the traumatic encephalopathy syndrome, which is synonymous with CTE probability in the living, is number 1, substantial exposure to repetitive head impacts, a minimum of 5 years of football. If you have 11 plus years of football, your risk is substantially higher, essentially 10 times higher as with 5 years. Cognitive impairment is the number 1 core feature. It requires that it be reported by the individual, by their informant, or by a clinician. It represents a significant change from the cognitive level that individual had prior to finishing their contact collision sport activity. And of all the different cognitive things that can be studied, it required you to have problems with episodic memory or executive function. And actually, in most of the individuals, it's episodic memory, which is essentially list learning. It's new memory, recent memory that's most impaired. and it's uncommon for executive function to be off if recent memory isn't off as well, whereas in early cases, the episodic memory may be the only thing off and not executive function. And if it's being compared with standardized testing, these tests of episodic memory or recent memory and executive dysfunction should be at least 1.5 standard deviations below normative value. The behavioral dysregulation, again, requires it being reported by either self, the individual, or an informant or a clinician, that it represented significant change from their baseline, and that these behaviors are essentially the short fuse impulsivity things, and that they are not related to life events such as a divorce or financial problems from which one may be recovering. It's also essential that the cognitive and behavioral dysregulation be progressive, that essentially it worsens over at least a year period of time after the repetitive head trauma has stopped. So essentially the core features have this progressive course, or else they're not there or not considered to be there. It's also true that the conditions should not be able to be totally explained by some other neurodegenerative disease process or medical or psychiatric process. Once we've established that there is traumatic encephalopathy syndrome being present, then we determine what level of functional impairment the individual has. If they have no activities of daily living that are impaired, they're obviously independent. If it's mild, but they pretty much can carry out on their own the activities of daily living and their responsibilities, then it might be subtle or mild functional limitation. And then the three different levels of dementia, where you're going from having to have some of the activities of daily living be assisted by others to have full assistance, 24/7 care with severe dementia. Dementia is something you'll see in a minute that heightens the probability for CTE. In terms of other supportive features that we use delayed onset, because these symptoms typically occur 10, 20, 30 years after the individual has stopped playing, though not in every case. The motor signs that we look for are Parkinsonism or other motor symptoms like dysarthria or ataxia or imbalance, and in a small percentage of cases, motor neuron disease is present. The motor signs are not seen, though, in a high percentage of people with CTE, though they're there in a smaller percentage. Psychiatric features are anxiety, apathy, depression, or paranoia. Any one of those will click off the psychiatric box. And then other things that we use for supportive features are neurobehavioral dysregulation, extensive exposure, or mild dementia. So let's just kind of quickly summarize how we get into various levels of probability for CTE, and then I'll show you a schema of it as well. Suggestive CTE means you've met the criteria of adequate exposure. You've got cognitive, suggestive meets the criteria for behavioral dysregulation, meets the criteria for exposure. So it gets you into the TES category, but it does not have cognitive criteria. If you don't have criteria, the highest level of probability is just simply suggestive, which is the lowest. Possible CTE meets the TES criteria, and you've got cognitive impairment and 2 of 5 supporting features. And the supporting features were, once again, the delayed onset, the motor features, the psychiatric features, neurobehavioral dysregulation, and/or mild functional limitation. If 2 of those 5 are there, you meet criteria for CTE possible. All of these that are possible should have less than 11 years exposure. To get into the probable CTE, which means more likely than not, you meet the TES criteria, you meet the cognitive criteria, and you have 3 of 5 supporting features present, and you have an exposure that is greater than 11 years. To have definite CTE requires neuropathological confirmation. That's, of course, beyond living individuals. So to just look at it schematically, if you have substantial exposure, that's 5 years minimum, 11 years gets you into extensive. If you have core clinical features, if you have it not accounted for by anything else, and those core clinical features, either cognitive and/or neurobehavioral dysregulation, are progressive, then you've got the traumatic encephalopathy syndrome. Then you go to the functional level of impairment, and depending upon that, we come up with our probabilities for CTE. So as we look at, earlier I'd had a pointer, but the meets TES criteria, but no cognitive impairment, no on the left, gets you at the highest level of suggestive, which is the lowest probability for CTE. As we come down the scheme, the level of exposure to contact collision sport, if you've had 5 years to under 11, then you go off into that left category, and if you have 2 of 5 supportive features, delayed onset, motor symptoms, psychiatric, neurobehavioral, substantial functional limitation, 2 of 5, you wind up with possible CTE. On the other hand, as you're coming down, if you make it into the high level of exposure, greater than 11 years, then if you have 3 of 5 supporting features, you're going to have probable CTE. If you have less than 3 of 5, you will then drop down into possible CTE. So with this schema, we're able to have different levels of probability of developing CTE. And I think it's important to go through this exercise, even though it's not perfect, and even though it isn't absolutely certain whether anyone has CTE in the living. You cannot be certain of that at all. But I think it's very important to understand that you can treat the symptoms of CTE even if you can't treat the underlying neuropathology of it, and therefore, with proper treatment, hopefully Philip Adams would not have had the outcome that he did. And what those treatments are include, for everyone, proper exercise and diet, and then depending upon the areas of most maximal impairment, cognitive therapy, counseling for behavioral dysregulation and mood issues, as well as medications if needed as well. And with that, I thank you very much, and I'm very happy to take your questions. Well, I'm glad it was that clear. Jeez. Grant, where are you? Come up.
Hi. I'm curious how some of the younger NFL players, like the player you just showed, could get CTE so early in their life, and why you may have older players or retired boxers or something like that who will never experience CTE.
Yes, that's a great question. First of all, we don't know for sure the incidence of CTE in NFL football players because all of them haven't been studied. If you look at just the numbers of NFL players that died during a period that a paper was written in which 91 out of 92 NFL players that were studied had CTE. Now this is a selected group. These are all symptomatic people. Their families are worried that why they went crazy. And so it's not representative of your average NFL player. But if you just look at the absolute numbers we studied, and you look at the absolute numbers that died during that time period, about 2,000, that would give you an incidence of 8.9% of CTE in former NFL players during that time period. And we know that there are other players out there with CTE that we didn't study their brains or their brains weren't studied. Whether that is going to get you to 20%, 30%, 50%, we don't know. We do know that not everybody winds up with CTE symptoms that played contact collision sports, and most probably not everybody that plays contact collision sports develop CTE, at least symptomatic CTE, and that's the important thing. There are obviously other risk factors for who gets it, probably genetic factors, probably environmental factors, but what we know right now today is that we can correlate your risk with how many hits you took to the head over how long a period of time. And it takes a minimum of 5 years in football before that risk starts to go up. If you only played at the high school level, that risk isn't there, at least in the numbers of patients that have been studied so far. How many hits do you take over that period of time? Well, it's probably between 3,000 and 5,000 hits. So it's a lot of hits to the head before that risk goes up. And then the risk goes up tenfold if you played 11 years or more. By then, you have really taken a lot of hits, 8,000 to 10,000 or more. So there are a lot of factors that go into who's going to develop CTE and who's not, and we know about the exposure factor. What we don't know about are a lot of the other genetic factors. But what we also know is that hyperphosphorylated tau is a marker, and it's not the whole story. It's the neuropathological diagnosis of CTE, but also what's going on with at least the symptomatic CTE patients and patients taking this repetitive head trauma. It's breakdown of the blood-brain barrier, it's release of proteins that would not normally be released, it's tearing of axons, so there's an axonopathy. So there is a vascular component and there is a shearing component of white matter, fiber tracts, that's contributing to the symptoms of CTE that we don't yet have a good way to quantitate. So we're kind of focused on how much tau is there, but that's certainly not the whole story.
Thanks, Dr. Cantu. That was a great talk. I just had a quick question about like mindfulness and meditation and kind of its role in neuroregeneration for concussions.
Yes, if you were to look at that interdisciplinary graph that we put, mindfulness was up there because a lot of people with post-concussion syndrome and certainly individuals with suspected CTE, anxiety is a big issue. And anxiety is helped in many individuals significantly by mindfulness programs. Meditation also in that same category, as well as working with cognitive behavioral therapy as well. So clearly that's a part of treating individuals, especially with the emotional symptoms of anxiety and depression.
Doctor, thank you so much for your ongoing research. My question is towards females. A lot of the data that you delivered today was high-impact collision sports. We see an increase in females in concussions in soccer, hockey, other basketball. Wondering if there's any research being done to that, and if you could shed some light to that gender difference.
Yes, thank you for the question, because it brings up a very important point. Right now, we don't have a case of CTE in a female athlete, but we don't have very many female athletes total whose brains have been studied. I have no question that we'll probably see it. There's no reason to think that the female brain is that different from the male brain, that we won't see CTE. But it is true that we desperately need hundreds and hundreds of individuals, of female athletes that have played contact collision sport. The biggest need, in my opinion, in this whole CTE area are two things. One, of course, longitudinal studies that will probably never fully, truly be done, at least in my lifetime, but hopefully can be started. But then, most importantly, when we get enough of these brain donors who are in these high-risk categories to donate their brains, because tragically they've now lived their life, hopefully they've lived their life asymptomatically, because that's the brains we need. We need the brains of individuals with high exposure who don't have any ostensible cognitive, behavioral, or mood issues. Because those are the brains that are really going to tell us, are we missing a lot of CTE that's asymptomatic? And if so, why are they asymptomatic? Do they have just that much cognitive reserve that they can have a fair amount of disease but not have it show? Or are there other factors? But we desperately need those asymptomatic brains, and they're very difficult to come by, other than by the registry, because families are not going to donate dad's, or in the future maybe mom's, brain if they've lived a normal life and they have no problems, unless it's been the wish of that individual. I want to donate my brain to science so we can understand what has happened to me, even though I may be totally fine. Thank you.
Thank you very much, Dr. Cantu, for contributing so wonderfully once again to our summit. As Dr. Cantu was speaking, I was thinking about that despite him presenting all over the world, we have it on very good authority that this event is his favorite one to attend. His regular contributions to the ICS and his presenting here over many years, and the fact that Mrs. Cantu joins him on his trip to Niagara, certainly makes this statement real and credible. And be clear, we absolutely use this high praise in our recruitment of our world-class speakers each year. Even though our team kind of thinks we are at the top of his list, mostly because he likes to hear the wild stories of the Hoshizaki brothers and the relentless chirping of each other. It's kind of like watching an episode of Shoresy if you haven't experienced it before. Once our speaking prospects learn that they get to be added to the program alongside Dr. Cantu, and we share his endorsement of our event, they are in. It is only after they sign on the dotted line that we introduce them to Blaine and Warren. Doctors Letty and Cornway, you are in for quite an experience with us. It's time to take our first break. We have some people standing at the back. They're just not sure where the empty seats are. So when you head for break, if you could mark your spot by leaving something in your chair, so that folks at the back that are looking for a seat for the rest of the day know that if there's something not in that chair, it's fair game. Please make your way to some refreshments in the back, visit our exhibitor booth, and be back to the ballroom by just before 11:15 for our next presentation that will be broadcast live from Italy. Thank you. Enjoy your break.
So long.